But here we are, so we're going to give it, and this is a great topic. It's a topic that if at the end of the day, if you slept through most of this, and you at least walk out of today recognizing that this entity exists and that it's more common than what we thought, we have achieved a lot. Because when I started with Dr. Park talking about this, I myself was not as aware that this entity was becoming as common as it is. It's not new, it's been around for a while, but the awareness that it exists and the awareness that it is now an important group of patients seen by experts in pulmonary hypertension clinics is something that was actually new to me. And you guys know I have a little interest in diastology. And so if you walk out with only that alone, we have accomplished. So we know all that when we're in heart failure and we're short of breath, feeding pressures play a very important role in that. Left atrial pressures are elevated, and that produces what we call passive pulmonary congestion. And these patients frequently look like this. They have a great EF, and they have a really big left atrium, and they have a fair amount of diastology issues. And the entity has been defined in many ways. Patients that have a congestive state with a preserved ejection fraction and a fair amount of filling abnormalities in the ventricles. We know that this is a very common entity. You guys have seen this slide in multiple presentations by multiple speakers. By 2002, half of admissions were for diastolic heart failure. I think that's true today. And if you look at this slide here, preserved EF in red and reduced EF in black, they basically are sharing the frequency of hospital admission. So clearly, this is an entity that has become quite common, and the prognosis is not that great either. So if we look at people with systolic heart failure, over the years, they have had some improvement in outcomes, where over many decades, people with preserved EF heart failure have about the same. And you can see both have very grim outcomes at about 5 years. So this is a serious entity, one that has a lot of recurrences of admissions and not such a good outcome. So let's talk a little bit about some of the physiology behind this. Again, you have seen in multiple talks this type of concept of left ventricular pressure volume loop. And diastole here, pressure rises, ejection, returns back, and so on. And we're going to concentrate on this phase, the diastolic phase. And basically what we're talking about here is that in a normal ventricle, hopefully many of us sitting in this room, the ventricle operates in a phase of the volume pressure relation where it achieves a certain end-diastolic volume, is able to contract and maintain diastolic pressures in a normal range, and it also has a reserve. So the starting reserve allows the ventricle to get a little bigger with extra volume, has an increasing stroke volume, while maintaining diastolic pressures in a reasonable level. And that would be our sort of normal physiology. And if you could transmit that to pressures in a normal person, you have your pressures here that we teach our medical students in terms of the cardiac cycle. So you have your diastolic pressures that are nice and low, your left atrial pressure equally, your pulmonary pressures, systolic 25 or 30, and then PA diastolic and mean left atrial pressures, both are very close to each other and relatively normal, so that quite often we use PA diastolic pressure in ICUs and whatnot as a surrogate of left atrial pressure. So when things start to go bad in people that have heart failure with preserved EF, first thing that happens is relaxation is impaired. And this is kind of an exaggerated illustration of what happens. The pressure decay takes longer to come down. The minimal pressure goes up. All the pressures are risen. And of course, the pressure volume loop shifts this way, which is what we would see in this slide. Actually, this was a slide of a pivotal study done in 2004 by Mike Seil and Bill Gash, where they took almost 50 patients coming straight in with heart failure and preserved EF, and very quickly they tried to reach them to take them to do fancy studies in the cath lab. And what they found is that using high fidelity pressures, they all had slow decays of the LV pressure to the early relaxation, and therefore the left ventricular pressure was shifted just as I showed you in that theoretical slide earlier. This is real data from the patients compared to the controls, which are the hatch lines, were a group of controls that they also studied. So this concept is a true concept that when the heart is very stiff, relaxation is impaired, the curve shifts, patients are operating now in a higher starting pressure with a shift, and therefore the reserve is more in danger, so that a fluid load or anything can quickly get them up into levels of pressures that will elevate LAP, pulmonary venous pressure, and so on. And in fact, it can get to be really bad. I mean, if you throw in severe hypertrophy, hypertrophic cardiomyopathy, if you throw in ischemia in coronary disease, diabetes, hypertension, those shifts can be sometimes very impressive. And they can have very high pressures with a shift to the left of the pressure-volume relation. This is theoretical, and this is exactly what Mike Zile and Bill Gass showed in this group of patients. So this is the average data for the patient group versus your control. And exactly that's what they found. High pressures shift to the left of the pressure-volume curve, and the slope of that curve, which is a marker of stiffness, was elevated in those patients compared to the controls. So the theoretical things that I just showed you were shown very nicely in this group of patients that were studied, and that's why this is a very important paper that brought concepts into real findings. The good news, of course, is that we treat patients, we give them all kinds of goodies, including diuretics, and quite often we're able to partially reverse this, bring them either back down in their own curve, or actually get them to shift back to a curve that is more manageable, that brings pressures down, and that they can therefore function with less symptoms. Now, what we have always thought happens in the pressure department when we do this, when we have this type of physiology, is that we always have thought of wedge-driven or left atrial pressure-driven pulmonary hypertension, or passive congestion, that we have used that term too. I.e., if you look here at your pressures, your LV end diastolic pressure is way up with an atrial kick. Your LV pre-A kick pressure right here is very similar to your PA diastolic and to your mean left atrial pressure. So if you look at the mean left atrial pressure relative to the pulmonary artery diastolic pressure, usually they are within 5 millimeters of mercury with each other. Sometimes it can be up to 7. But they're close. And of course, pulmonary artery systolic is going to be elevated based on two things. Okay? How much is that passive congestion of the lungs, A, and B, how much flow is coming in. If you have a high output, then you have a more flow coming into that system. That's going to elevate your PA systolic even more. If you were in severe systolic heart failure with low output, the PA systolic may be lower because you don't have that much flow going to the lungs. So the PA systolic is a combination of multiple factors. So this is what normally we think about when we talk about heart failure in these patients. Actually, both systolic and diastolic, to be honest. So we give diuretics, bring some fluid out. We bring the LAP down. Your PAD comes down. Your PAS comes down. Patient is happier, and we're all happy, and we feel like we did a great job. And this is one of those patients, typical patient, hyperdynamic heart, big left atrium. And we look at the diastology by Doppler, which I'm not spending too much time. Those are topics we have discussed before and probably will discuss again. But we have basically a ratio of E velocity to your annular velocities that is very high. And this is what made Dr. Naga famous 20 years ago with this pivotal study that showed that E over E prime ratio could be used as a surrogate for mean left atrial pressure. And it's one of the ways we do clinically when we give you your echo report suggesting whether the LAP is normal, elevated, and whatnot. So this would be a typical patient. In fact, this patient had a PA systolic pressure estimated close to 50 and responded to diuretics and was a fairly typical patient as I just described. And even in systolic heart failure, actually, it's kind of the same thing in many ways. The only difference is that patients with systolic heart failure, when they decompensate, they frequently develop a big V wave in the LAP, and that causes more of a restrictive type of ventricular filling in their Doppler patterns. So this is more typical of what we see in those patients. But it's very similar. It's the same concept. Even in systolic heart failure, we see that the LAP is elevated with this high V wave, and the PA diastolic to mean left atrial pressure gradient, again, is relatively closed, within 5, maybe up to 7 millimeters of mercury. And therefore, we often use Swan-Ganz catheters, PA diastolic pressures in the ICU as a way to manage these patients. So here we have this 88-year-old fellow, very sick, class 4, okay? Bad heart failure, low output, low EF, big left atrium, very restrictive filling in the transmitral velocity, PA systolic pressure around 70, high RAP, very high velocity of tricuspid regurg. In fact, even the pulmonic velocity has a little notch, which is typical of bad pulmonary hypertension. So this is a guy that has bad EF, low output, and yet has these pressures up to 70. And the report actually came out with a comment, oops, I'm sorry, I thought I had it there, let me go back. With a comment here saying, consider secondary reactive pulmonary vascular hypertension, investigative hemodynamics may be warranted. Because it was felt that PA systolic of 70 was kind of like, whoa, way out of proportion to everything else we were seeing. So is this a case of pure passive congestion, or is something else going on? And the something else that is going on, or maybe going on in that patient, is that yes, the left atrial pressure is very high. Yes, your LV diastolic pressures are high, but now the patient has developed a gradient between PA diastolic and left atrial pressure, or pulmonary wedge. And by convention, the experts have agreed somewhere around 7 or more to be considered too much of a gradient, implying that there is already now pulmonary reactivity, vascular reactivity, kicking into the equation and making your PA pressures even higher than they would be just based on simple vascular passive congestion. 85-year-old lady, also very sick with dyspnea. Now this one has a good EF, nice EF, big left atrium, nice EF. Again, has a restrictive-like feeling pattern, even though the EF is normal. Very low relaxation by tissue Doppler. A TR of almost 4, and therefore a PA systolic pressure around 70 also. And in fact, again, same thing happened with her report. Findings are consistent with diastolic heart failure and secondary hypertension. Invasive hemodynamics assessment might be needed to exclude a pulmonary vascular component. Because again, I read this and I was concerned that this PA systolic, again, is getting kind of out of hand. It's higher than you would be thinking, just purely on a very simplistic passive congestive model. So again, very similar. This would be diastolic heart failure instead of systolic, but the concept is very similar. They frequently have more of a restrictive pattern. In other words, they have more often a big V wave when they get to this level. And again, they have a gradient between PA diastolic and mean left atrial pressure, suggesting a level of reactivity of the pulmonary vasculature. Another patient, 74. This one is a teenager. This one is younger. Okay. Grade EF. Again, huge left atrium. This is 100% a feature. Big left atriums. Again, pseudo-normal pattern or somewhat restricted pattern. Pulmonary veins are typical of a big V wave with high LAP. Poor relaxation. TR velocity, 54. Pressure gradient, but look at the RA pressure. Huge, with a systolic retrograde flow to the hepatic veins. So again, a PA systolic pressure estimated around 70. So I just showed you this, a case with systolic and 2 cases with diastolic, just to show this concept of very severe pulmonary hypertension in the presence of also heart failure. And again, the same question. And look at this patient. This was very interesting. This is taken right off our files. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 admissions since 2007. 1, 2, 3, 4, 5, 6 of them from 2013. Whew. Keep coming back, okay? And every time the echo looks the same. I look at a bunch of these old echoes, same thing. Good EF, big left atrium, you know. So is this another case of the same problem? And have we been managing this patient properly? You know, obviously, patient is under the care of a cardiologist. He's a good cardiologist. I know him. Probably we'll be using diuretics, you know, the whole thing that we normally do. Patient keeps coming back. So this is an interesting concept. Again, I don't think it's new. It's been around for a while. I think the recognition that it exists and that it creates problems is what is becoming more new. These are terms that have been used. If you go to the literature, passive versus reactive, fixed versus irreversible, unresponsive versus responsive, out of proportion versus proportionate. All of those terms have been used to describe this type of patient that has a wedge-driven reactive pulmonary hypertension. So the left atrial pressures are high, but on top of that, they have pulmonary vascular reactivity. How old is this? This is old. Actually, this is even older than Dr. Cook. In fact, it may be just as old as Dr. Winters. Look at this. Look at this. This is kind of fun. And this is actually not the first one. This is already in the middle of the ground. 1954. Dr. Winters, what were we doing in 1954 with catheters? What were we doing in 1954 with catheters? Cournants, right? Right heart, Cournants? Yeah, not much. In fact, when I was a fellow, Dr. Alexander used to tell me that he trained with Cournant. He would come. He and his other fellows would come in at 4 o'clock in the morning to prepare the lab for Dr. Cournant to walk in at 7. That's how long it took to prepare the setting, to put a Cournant catheter and do a simple right heart cath that today we throw in with a balloon swan gas. Okay. So, the nature of pulmonary hypertension in mitral stenosis. Look at some of these pressures, guys. So these were people that had PND or orthopnea. Look at the simplistic way they were looking at this stuff. A group that had PND or orthopnea and a group that didn't have PND or orthopnea. Look at some of these pressures. They were out of the sky. You know, one guy here had a 160 PS systolic. I mean, these were sky-high pressures. You know, less in this group. So this whole concept of severe pulmonary hypertension in top of an elevated LAP is not new. It's pretty old. In fact, when I trained and we still had a lot of mitral stenosis, it was one of the fears we always had in surgery. Patient goes in, we crack the valve, everything looks good, the PA pressures don't come down. So this concept of reactive pulmonary hypertension is not new. It's old. It just happened that mitral stenosis disappeared, went away. It's not a problem anymore. Now it's being replaced by a whole new disease. And we kind of forgot that the physiology could still be playing a similar role. And therefore, this entity is in existence. So how common is this? And this is the last part of my slide. Presentation is how common is this. And again, this is hot off the press, a publication that was just published in July. So they had a retrospective group and a prospective group. In the retrospective group, they went back and looked at 1,000+ cases of heart failure. And they divided them into low EF, preserved EF, okay? Very typical. They went down through, with the data they had, hemodynamic data, and they found that 12% of the systolic heart failures had the entity where the PA diastolic pressure minus mean wedge was 7 or greater, suggesting they had this entity. Same percent for the diastolic heart failure or preserved EF, whichever term you guys like best. Very similar incidents. Then they went to a prospective group that they did prospectively of close to 400. Same scheme, very similar, 14, 12. So somewhere in that 12 to 14% probably is the prevalence of this condition. Well, that doesn't sound like a lot. But if you look at the universe of pulmonary hypertension patients that are seen in a pulmonary hypertension clinic, primary pulmonary hypertension is not a very common disease. So when you look at, yes, patient with primary hypertension, and then you throw this into the group, you can see that a pulmonary hypertension clinic will be seeing a lot of these patients, which is one of the things that Dr. Park told me when we met each other and we were talking about the business of pulmonary hypertension. And she said, nowadays we're seeing a lot of these patients with diastolic heart failure in our clinic. And this is why. This is, in the universe of things, is a relatively common situation. And the same group, using the retrospective data, because they had more years of follow-up, look at that, these are the number of months they could follow these people, found that those with reactive pulmonary hypertension in red had a worse outcome compared to the ones that didn't have the reactive component, with about close to 50% mortality in 5 years. And this is systolic. Look at diastolic. Even worse. So clearly, having this component of pulmonary vascular reactivity in top of the high LAP worsens the outcome. So this is where I'm due, because this is how much I know about this. Thank you, guys. So it's my pleasure to introduce Dr. Myung Park. Dr. Park joined us in the summer. She is the new chief for our division of heart failure. She has been in the heart failure business for many, many years. She's done the transplant, the LVAD. She ran the advanced heart failure service at Oceanary in New Orleans. So she's been there, done that. But then subsequently in her career, she developed an interest in pulmonary hypertension. And for the last decade or so, has really become one of the national experts in pulmonary hypertension from the cardiology side, which I think is very appropriate given just what I share with you. So she's coming to us. She's the leader of the heart failure division, but also is going to help us with Dr. Ash to set up a robust pulmonary hypertension service. So I'm hoping that she will help us a little bit with giving us some clues of how best to detect this condition. What are sort of the proposed pathophysiology mechanisms that are sort of circulating in the literature? And of course, can we do anything about it? Are there any forms of treatment that we can offer these patients so we can reverse some of these outcome curves that I just showed you? So it's my real pleasure to introduce Dr. Park to you. And we have to switch laptops. So while we switch laptops, you want to ask me any questions? Yes, John.
That was a quick review. Where is the resistance occurring? In the individuals that have the pulmonary reactive hypertension, where is the resistance, increase in resistance? Is it the small arteries that are distal to the balloon? Is it the arterioles? Is it the venules?
That's a great question to introduce Dr. Park. Any other questions?
Good morning. It is a pleasure and honor to be here this morning. Thank you, Dr. Quiñones. And I really would like to thank Dr. Q for coming up with this topic to discuss. It is indeed something that has been vexing to all of us. I think we can collectively say that we see these patients in our clinic day in and day out. They do cost quite a bit in our efforts to take care of them. We are still struggling, actually, to be quite frank, to understand what this whole etiology is. But Dr. Q has asked me to address some questions, and I'll do my best to do so. Okay. So just a few known facts. So the prevalence of this condition is more than half of all patients with heart failure. And the mortality is enormously high. Just because there's a normal ejection fraction on the echo does not mean that the patient is well. Normal EF does not equal normal heart. So a 5-year mortality actually exceeds that of a reduced EF, as Dr. Q has just shared with us. Morbidity is also high. These are the patients that are frequently in and out of the hospitals and our emergency rooms and our clinics. And the decompensation rate is also higher than the reduced ejection fraction. Profound disability and symptomatology that equals or again exceeds reduced EF. However, if you add one more layer to this of pulmonary hypertension, RV dysfunction, they are definitely independent predictor of poor prognosis, irregardless of any other comorbidities. Now, unlike systolic heart failure, where we've been really at trying to find out how to improve outcome in various ways, and actually I think we've been quite successful, and pulmonary arterial hypertension, where we now are able to help patients live longer better, no clinical trial to date actually has identified treatment to be shown beneficial. And now why is that? And this has been the topic of discussion in many different circles. Now this, I'd like to take a step back and go over the clinical classification of pulmonary hypertension. This is from the most recent meeting in Nice in 2013. And you can see that there are 5 subtypes of pulmonary hypertension. This is clinically speaking. One, the PAH, this is what was called primary pulmonary hypertension, even actually still is called that in many circles. The idiopathic form, the heritable form, let's see if I can do this. Okay, heritable form, and the drug toxin-induced newborns. And of course, what we see a lot is those with comorbidities, like connective tissue disease, scleroderma, CREST, a very high risk factor for developing CTD, HIV infection. When I used to work in Maryland, we had a high cohort of HIV-induced PH, very, very bad prognosis. Portal hypertension, congenital heart disease, and schistosomiasis. So this is where we have all of our drugs approved. This is where we've been able to make enormous progress in the past 10, 15 years in PAH. And then there's PH linked to left heart disease, lung disease, CTEPH. This is the program that we're going to be embarking upon here at Methodist to form. And PH with unclear multifactorial mechanisms where sarcoid, end-stage renal failure, hemolysis, sickle cell, they all fall into. But as I stated, this is where we have all of our medications. This is where we have failed to show any success in getting any drugs approved. And if you look at the picture, just like Dr. Quiñones mentioned, you know, this is a little bit misrepresenting because actually, this is about 15,000 people in the U.S., whereas this is about 6 million. You know, so you do the math. And we are grappling to how to treat people that suffer from pulmonary hypertension due to left heart disease, especially those with diastolic dysfunction. Now, probably one of the most grappling fact is that we struggle with is that this entity just represented in so many different ways. And I'm just representing 3 clinical types here. Those that with exercise-induced pulmonary hypertension, a patient that comes to you, they're fine if they're at rest, of course, but if they try to do anything, they get short of breath. But if you look at them on the echo-wise and otherwise, I mean, they're actually doing pretty okay. Volume overload. Those that have a salt sensitivity, those that have a recurrent fluid overload, and of course, okay, as I was saying, pulmonary hypertension, RV failure, people that have more of a severe form of diastolic dysfunction, have more form of volume overload, frequent hospitalization, and of course, elevated PA pressure and evidence of RV dysfunction at rest on echo and hypertrophy. So the question is, how do you evaluate these patients, how to take care of them? Now, I'd like to start with some basic definition. This is from the most recent 5th World Symposium on Pulmonary Hypertension that was held in Nice. I had a pleasure to be one of the writing groups and participant of this group. There were about 80 of us from representing different parts of the world, and lots of arguments, discussion, and projections as to where this field needs to go. Now, this is as basic as it comes. However, even this was modified in the 2013 meeting. So pulmonary hypertension, hemodynamically defined, is a mean PA pressure greater than or equal to 25 millimeters of mercury. I mean, that itself is simple. Now, pulmonary arterial hypertension is the mean PA pressure elevation with a wedge that's less than 15, and with PVR greater than 3 Wood units. Now, the PVR actually was taken out at the previous meeting and then put it back on at the 2013 with the recognition that you really cannot look at pulmonary hypertension and RV dysfunction without accounting for cardiac output. So there was, amazingly enough, a lot of discussion about the appropriate use and placement of the PVR, and I, for one, are happy that it's back here. Now, if you go into the realm of pulmonary hypertension due to left heart disease, aka group 2, it gets a little bit more complicated. And this is just a pictorial form that I formulated just to represent this in sort of a different way. So this is the pre-capillary pH or PAH, and this is post-capillary. This is the group 2 elevated wedge pressure. And then if you consider the mixed picture, as Dr. Q stated, this is the out of proportion. Now, we usually use a TPG. That was the how we used to define this in a loose sense. There was never any concise definition. Another problem that we've been having. And so between the TPG and the PVR, that's how the out of proportion was defined. Of course, passive means that everything is due to fluid. If you diurese them, they go back to being normal. And whether they react to diuresis, you have either fixed pulmonary hypertension or reactive pulmonary hypertension. But it was felt that this was not sufficient, actually, in order to give a uniform definition of what pulmonary hypertension, mixed pulmonary hypertension, out of proportion pulmonary hypertension really is. And this took an enormous amount of debate actually at the meeting. And what the working group came out with is several proposals. One is, what are the traits that we want to have for our hemodynamic marker? And I've listed some that was proposed by the working group. You want it to reflect changes in the pulmonary circulation. That seems logical enough. Be a clear marker of pulmonary vasculopathy. Be as least dependent on the changes of wedge pressure as possible. And I think that is a very important factor. Be minimally influenced by the changes in blood flow and the stroke volume, and it should reflect the changes in the compliance as well as the distensibility of the pulmonary arterial system. So it was felt that by looking at all the work that has been done in the past few years, that diastolic pressure was less influenced by wedge pressure and stroke volume than transpulmonary gradient. So it was proposed that we use DPG instead of the TPG, normal value being about 1 to 2, abnormal as in heart failure greater than 5. Prognostically, it's about greater than or equal to 7, as Dr. Quiñones had presented. And precapillary, i.e. PAH, those that have a large gradient between their pulmonary arterial system and their left sided filling system is greater than or equal to 10. So this is what has been proposed by the World Health Symposium. The combined post-capillary and precapillary, or CPCPH, be defined as wedge pressure greater than 15 and DPG greater than or equal to 7. Now, the story doesn't end there because this has been under a lot of scrutiny and with groups doing retrospective studies looking at, is this really a good marker? And the answer has fallen actually anything but yes. So now, yes, I told you this is still an ongoing debate. The latest consensus that came out of the European Society of Cardiology states that, DPG really isn't good enough. We really need to combine it with another factor. Of course, PVR is what they have proposed to add as using with DPG. Now, the reason I go through all this is, one, you'll see this in the literature, but number two, I think this is one of the reasons why we are having such a hard time actually being successful in defining our patient population to study, knowing what the purpose of the therapy is, and see what the primary outcome of our set proposals are. So if you look at the literature and all the different studies been done, the definition ranges from many different types. So this all is an effort to really tone down, give a uniform definition so that when we do research, we have the same common language. So I hope this does work, but we shall see. So as you know, we live in the world of numbers, and it's garbage in, garbage out, or good data in, and you can get some good information. And there are a lot of pitfalls in assessing hemodynamics. I've done cath for 20 plus years, and I've seen many different scenarios where I know getting the numbers that this is not in the right position, and so on and so forth. The left-hand side shows you the patient with a true PAH. You can see the marked elevation of pulmonary hypertension. This was initially represented as a wedge pressure. Of course, this is an underwedge or hybrid tracing, falsely elevated PA pressure. This is a true wedge, where you can see the A wave and V wave that is crisp and that's distinct. Of course, we have tricks of the trade that we check on the fluoroscopy, check a O2 sat in wedge position. We also make sure that there is an appropriate respiratory variation. all of the things that we do to make sure that the number that we report really do truly represent the patient physiology. Now, in the real world, as we know, and all of you know, that does not happen 100%. And this has been something of a hot topic as well, because so much depends on that wedge pressure number. Now, this is from a study looking at retrospectively over 11,000 simultaneous left and right heart cath, almost 4,000 with pulmonary hypertension. And you can see that if you look at this square here, these are the patients that were misrepresented or misdiagnosed as having pulmonary arterial hypertension or group 1 PAH. So these patients actually, if you look at the LVEDP, has a high LVEDP, so they have a heart failure, but they were diagnosed as PAH and was probably placed on treatments for pulmonary arterial hypertension. Group here has misdiagnosed as PVH. So they, on the opposite, actually missed the opportunity to be placed under life-saving therapy and instead was probably treated as heart failure. So this is how important correct hemodynamics is. Now, of course, one of the greatest invention, computer, has been actually implicated and blamed for a lot of these mislabeling, and there has been study to demonstrate that a lot of it is true. If you just rely on a computer-generated number, you're usually under-reading what is usually a true wedge pressure, LVDP. And this study showed that end expiratory is the number that you want to achieve, you want to go with. And if you look at these differences here between the computer read and end expiratory is quite large. And the two scenarios, obese patients and those with lung disease, huge swings in your pressures and your respiratory pattern. And it is not always that easy to know what your accurate end expiratory or your wedge pressure is. But we really do give our best. And at times we admit that we really do have to do a left-sided study to get an accurate LVEDP. Now, there are other circumstances when you get that 64-year-old with diabetic coronary artery disease, history of AFib, and she's short of breath. But if you do an echo, it looks actually quite good. And if you do a right heart cath, it's actually normal and near normal. So do you take that at face value and do you say, well, you're normal, there's nothing wrong with you. Your shortness of breath is, you're deconditioned, you have asthma, anxiety, which actually has been what has been said in the past. So there has been, a subgroup of people that practice in this field that has been a huge proponent of doing provocative maneuvers, either exercising or fluid challenges. And you can see that from the top is the exercise and the bottom is the fluid challenge. And you could get a normal number baseline, and you could get exercise-related differences, and same thing with fluid challenge. The difference is you could get numbers, but what we lack is any predefined, well-done study to let us know what the abnormal value is. And this is really dependent on the age of the patient, comorbidities, gender, and some other criteria. So we can get a number, but if you have a wedge pressure of 25, is that abnormal? Is 30 abnormal? In the past, one of the definitions that used to be a part of PAH is exercise-induced wedge pressure, mean PA pressure greater than 30. So that used to be part of the definition. That is not so any longer, with the recognition that there's too many variables and we really don't have the data to state this. But this is still used because I think it does give us some reflection on the compliance and the physiology of the ventricle and the pulmonary system. So again, it's not that it's not used. I think it has a place when you have a patient that you're strongly suspicious of diastolic dysfunction, but the numbers and other studies do not indicate that, and to see how they do with challenges. Now, the people out of Mayo and Olmsted County, there's been a lot of studies coming out of Olmsted County in the past, I think about a couple of years. It must be the mecca of diastology. But the Mayo group has done really some good studies. This one demonstrating that if you compare to two different stressors between exercise and between a fluid, they're not equal. They're not equal amount of stress for the left ventricle. And actually, comparing to controls, And those with HFpEF, you could see that compared to saline and exercise, that exercise induced markedly greater degree of wedge pressure changes than saline. And you can see from the slope of the curve here that exercise is stated to be a better form of stressing these patients to study this phenomenon. So I think this is something that is worth noting. So mechanism, switching gears a little bit. When we consider the mechanism, we really have to consider the whole kit and caboodle, as they say, LV, PA, and the RV. Now, the mechanism of PH due to left heart disease, this is just one representation. There are many different types. It starts, of course, as a passive increase in PA pressure due to diastolic dysfunction, exercise-induced MR, chronic overload by the increase in wedge pressure. But the endothelial system, we've learned a lot in the past 2-3 decades and learned to utilize it to treat patients. But then there's also further vascular remodeling for the patients that do not have the ability to respond to treatment and any modalities that go to progress significant pulmonary vascular disease and RV failure. And this is, again, a study that came out of Johns Hopkins, sort of pictorially depicting the top where this is a normal pulmonary artery. It's a very thin compliant vessel attached to a thin-walled RV. And as disease progresses, you can see that you get a more of a abnormal PA endothelium, along with some hypertrophy right ventricle. And of course, you get some constricted and stiffening of the pulmonary arteries here. And you get a lot of loss of microvessels during this time. And you get dilatation of the right ventricle as these cells proliferate, there's further remodeling, and you have complete obliteration and obstruction of the pulmonary arteries. Now, to be fair, this is an example of pulmonary arterial hypertension, not pulmonary hypertension due to left heart disease. However, if you look at some of the pathological from autopsy studies and so forth, if you look at the lung beds, they're very similar. So when you have an end-stage disease, whether it's coming from the primary source of pulmonary arteries or it's a backward transmission, if you will, from the left heart disease, the end result for those who are genetically predisposed, many people think, it is really similar. So what the result is from that ongoing dilatation, you end up with an RV and PA that is uncoupled, and therefore patients suffer from an ongoing onslaught of heart failure and readmissions. And we are very well aware and familiar with the consequences having a bad RV. When you have pulmonary hypertension, you get increased wall tension, you get the dilated RV, and you get decreased RV output, and this leads to hypertrophy, RV ischemia, and septal shifting of the LV, because they're all connected within the septum, and that also leads to further LV dysfunction. And you have a limitation in the preload reserve from the ongoing and worsening tricuspid regurgitation, and all of it leading to decreased LV output and further impairment of biventricular function. And the price that we pay, or the patients pay, for having a chronically elevated CVP is of course, multi-system bound from affecting the kidney function, hepatic function, not to mention the symptom of ongoing edema. Now, this is another study that came out of Mayo Clinic showing that now just studying what is the pathophysiology or mechanism of the uncoupling and coupling, and can we get any insight into this? And what they did was they took 39 heart failure patients with HFpEF and 18 patients, and they did extensive invasive studying using dobutamine, initially 5 micrograms and then 10 micrograms each for 5 minutes. And what they report is that patients that have actually HFpEF have a greater response to this beta agonist, with a further decline in the PA pressure, TPG, and PVR, and actually and pulmonary arterial compliance than the control patients. And now these patients actually are those that have a very early stage of HFpEF. So if you look at the RV structurally on the echo, they appear normal. So again, this is, I think, very important finding, demonstrating that compared to normals, that their ability to augment, respond, and distend and decrease the pulmonary vascular load with dobutamine is so much more so than controls. So the authors conclude that PH in the early stage of HFpEF is related to partially reversible pulmonary vasoconstriction, coupled with RV systolic and diastolic dysfunction, even in the absence of RV structural remodeling. And pulmonary vascular tone is more favorably responsive to beta adrenergic stimulation than controls, suggesting a potential role for this for treatment in a HFpEF population with pulmonary hypertension. So I would like to use that as a segue to kind of discuss in the remaining as to what are the treatment options for HFpEF. Now, in the treatment, we have utilized the pathways of three different systems: the prostanoids, the endothelins, and nitric oxide. Now, the prostacyclin augment the cyclic AMP. The endothelin block the vasoconstrictor and through ETA and ATB, and of course the L-arginine through the eNOS system and nitric oxide system increase the cyclic GMP. And of course, this has been a source of great interest in the field of heart failure and pulmonary hypertension, but this has also been used very successfully in pulmonary arterial hypertension. Now, I've just listed for an overview of all the drugs that we have at our disposal for PAH. There are 12 of them. 20 years we had 0. Now we have 12 drugs, FDA proven, to treat PAH, the orphan disease that afflicts so little number of people. But however, we don't have any for group 1 and group 2. And why is that? Well, it's not that we haven't tried. There has been study after study after study, because even from a pharmaceutical company standpoint, they're interested in making an impact on heart failure. There are lots of people. I mean, it equates to a huge economic difference. But if you look at the epoprostenol with Flolan and Bosentan, the ERAs, and these are all ERAs, you could see that they're all negative study. But if you look at the primary endpoint, except for this is survival, and this was stopped early due to increased rate of death, there is very variable kind of definition as to what the endpoint is. And this kind of brings to the discussion that I started earlier: why have we failed? And there are many different reasons. Defining the right patient population. And if you look at the studies that I've just showed you, they really were not stratified by pulmonary hypertension. There was no predefined need or indication to have PH to enter those studies. Hemodynamics were not systematically performed, and preliminary optimization of volume was not required. Defining primary endpoints. How do we measure success? Is it exercise capacity, echo, hemodynamics, or RV function? And I think this is what the field is moving more towards to. Dose. A lot of those studies use very high doses in order to get systemic effects. Well, is that the right strategy? And duration of the study. Just like the PH studies, those were very short-term studies for most of them. Is that really long enough to get a difference in the LV and RV? Now, I'm going to skip this in the interest of time and go to nitric oxide, the cyclic GMP signal transduction system. As I've stated, sildenafil, one of my favorite drugs, is a very highly selective for PD5 over PD3. Of course, PD3 is what Mironone and some of the other drugs target. And there's no significant effect on the systemic blood pressure or heart rate. There's some evidence of increase in coronary perfusion, improvement in endothelial function, and there's also evidence for direct anti-hypertrophic effect on the cardiomyocytes. Now, there's been incredibly large number of studies done using this drug, and publication after publication, but just a few that I would like to quickly mention is this is one that came out of Mass General from Greg Lewis's group, that demonstrating that when he tested a patient cohort with just one dose of 50 milligram of sildenafil and tested the hemodynamics, the ones who showed improvement were, again, only the ones that had pulmonary hypertension. If you look at the ones that did not have PH, there was really no improvement in exercise, peak workload, or VO2 max. Now, when this was carried out in a 12-week fashion in a prospective way, what they found out was that there was an improvement in the peak VO2 on a long-term scale, change in 6-minute walk distance, and a decrease in hospitalization. Now, this has also been shown to demonstrate improvement in those who undergo MCS with pre-sildenafil and post-sildenafil in both the cardiac output, mean PAP, and decrease in PVR. And you can see that there's also a marked decrease after they have a MCS placement. And this is another group of study that's showing that not only does it decrease the pressure, it also attenuates hypertrophy and remodeling. This is a mouse model with a sildenafil treated, as you can see, and this is on a group of heart failure patients showing that after a 16-week of treatment, and actually this is 1 year, there's definitely an improvement in the overall remodeling of the left ventricle. So there's also been further studies in using this drug in patients that were not initially approved for listing for transplant, and they were treated with sildenafil, and then showing that it is safe to use sildenafil in this cohort, and you can actually decrease the PA pressure enough so that you can list them and then safely wean them afterwards. And this is another study, and I promise it's the last one, showing that for the out of proportion undergoing cardiac surgery, and in this group actually studied both INO, inhaled nitric oxide, and sildenafil, showing that for all the patients undergoing valve surgery and CABG, that there was a combined and an additional synergistic effect producing a larger pulmonary vasodilation than either drug alone. But this group, this panel here merits some attention in that when you do use sildenafil first, that there is a greater chance of course, systemic hypotension. So there was a lot of interest, if you will, on the RELAX trial. This is the first and only that we have so far randomized clinical trial in HFpEF with sildenafil, and all the others were just reports of clinical trials from single centers. So we were very happy that this was being done, and we had high hopes that we can get some good studies. And what we found out was that in 216 stable outpatient patients with heart failure, those with EF greater than 50, elevated BNP, they were treated with sildenafil for 20 TID for 12 weeks and followed by 60 TID for 12 more weeks. And the primary endpoint was change in peak oxygen consumption after 24 weeks of therapy. Now, this was, I must admit, a rather large amount of disappointment because it was not shown to be a positive study. It was a negative study. And you can see all the secondary endpoints here showing no statistical difference. And not only that, it was we did learn some things from this study. One is that there was a high prevalence of chronotropic incompetence in this cohort, and also that there was a modest but statistically significant worsening of renal function in those who were treated with sildenafil. So I think this has put some break, if you will, in our enthusiasm for treating all the patients that we saw and come across with PH, with left heart disease in prescribing sildenafil. Not that it's not done, just I think people are being a little bit more careful in carefully identifying the population. In order to determine some of the etiology, and I'll wrap up in a few minutes, is the group that was the head of the RELAX study in Mayo Clinic really tried to kind of tease out, can we find out why we had this negative study? And out of the cohort, 48 patients underwent very extensive non-invasive testing, and what they have found is that those who got the treatment drug, there was a modest system afterload reduction, improvement in endothelium-dependent vasodilatation as they tested with reactivity, and a modest decrease in LV contractility. And this was shown to be from workload that they calculated, and was a bit of a surprise to the investigators and actually to all of us reading it. So what they propose as possible scenario is that do we need a drug that has a more chronically sustained improvement in endothelial function than sildenafil? And or could it be that the deleterious effect that sildenafil has on the LV offsets any kind of benefit that you see in the pulmonary vasculature? And so these are still ongoing discussions because this was just published and presented. So this brings me to the final group of medications that we have to work with, and this is actually a newcomer. This was just introduced, I think, about a couple of years ago, soluble guanylate cyclase stimulators, and this is a pictorial representation of how this drug works. There are two drugs that's currently being studied for heart failure, one riociguat and one invericiguat. Riociguat has been approved for PAH, And this has a dual mechanism of action. One, it sensitizes the SGG to its endogenous nitric oxide, but on the other hand, it directly stimulates SCG to cyclic GMP independent of the availability of nitric oxide. And if you remember, physiologically speaking, in heart failure and pulmonary hypertension, there are decreased availability of nitric oxide. So this drug actually can be potentially effective regardless of availability of NO, and it can be a dramatic increase in cyclic GMP, of course, which produces vasodilatation and decreases further cellular proliferation. That because of the interest, there has been a huge amount of effort in studying this drug with this therapy. Just two quick studies that I'll mention. One is LEP trial in systolic heart failure. And this is showing that in studying 3 different doses, you could see that the cardiac index and SVI increased without change. It was not a very positive study, but it was a signal that it's safe, well tolerated, and this is something that we should look forward to. And the DILATE study, this is on diastolic dysfunction or HFpEF. There was no change in the pulmonary artery pressure or increase in cardiac index, but again, a signal that we should study this further. So you will see these studies coming out further in the future. So to wrap up, current status in clinical trials in HFpEF. Now these are not just for pulmonary hypertension, but this is the whole spectrum of heart failure, both reduced heart failure and preserved heart failure. And you can see that between the beta blockers, ACE inhibitors, and DIG, there's not that many places here that you see or as a yes or a successful venture to treat these patients. And so the question and the dilemma is, how do you treat them? And the recommendation correlates that. If you look at the ACC recommendation, if you look at the level 1 grade recommendation, control blood pressure and use diuretics. I mean, and of course, treat the underlying comorbidities. So this is the current state of heart failure in preserved ejection fraction in 2015. However, there are some more things coming along the way. As I've stated, the SGG stimulator studies are very promising, and in both Socrates, they are reduced and preserved arm. Again, this is to study both cohorts of ejection fraction low and high. And then macitentan, this is a newer second generation ETA. Melody 1 is studying the safety and tolerability in heart failure, and Soprano, which we are part of, macitentan in pulmonary hypertension post-LVAD. So I think in the next 5 years or so, we should get more of a direction how to better handle these group of patients. So some take-home thoughts. This is a very vexing, common clinical dilemma. There are independent prognostic indicators that we've well recognized. Obtaining accurate hemodynamics is a key. And I think for now, we need to recognize what the treating, what the most inherent underlying condition is. Is it the left heart disease or is it PH? And if it's both, consider pulmonary vasodilators, but do it very carefully after a very thorough evaluation. And with that, thank you for your attention, and I'll take any questions. Thank you.
Thank you, Myung, for very thorough. One thing that I like to make a comment is that I truly believe that the echo lab is a starting point for many of these patients, and I think anybody that we see in the echo lab that has a good EF, patient has heart failure clinically. They have a good EF, big left atrium, and PA pressures that are exceeding 60 are likely to be this kind of patient that we're talking about today. And I will encourage every cardiologist to do a right and left hemodynamic, because you really, if you look, the wedge pressures are not easy to get always. And the LV diastolic pressure before the A kick is a very good indicator of mean LAP. So you could have a simultaneous pulmonary artery tracing with your LV tracing, and you could very easily detect that gradient between PAD and left atrial pressure by having the LV pressure with the PA pressure. I have been in the cath lab many years, and I can tell you the wedge pressures, whether it was done with Curnan and now worse with Swangans, can be extremely misleading. So I would recommend everybody here who takes care of those patients to really do a well-done LV and right-sided hemodynamics. Because the only way that we're going to truly detect them Now, whether we can take care of them, that's a different story. But at least we can recognize the entity better than if we just either stay with echo alone or do a quick right heart with all the problems that it has. So that's my 2 cents plea. Open for questions?
Dr. Q, Dr. Park, thank you for that wonderful overview. I echo your comment. In the cath lab for the last 8 years, we work closely with the pulmonary service. We always do an LV EDP when we do the right heart cath, at least one time to ensure, even though sometimes we get a good wedge, and it just really confirms that it's not related to heart failure. So my question, Dr. Park, if you can comment for the group, historically we're doing nitric oxide testing in the cath lab to help prognosticate and to tease out those who are responders to calcium channel blockers in the setting of pulmonary arterial hypertension. I'm interested in your comment on the potential role of nitric oxide testing in those with heart failure out of proportion, either from a prognostic or to help curb challenges post-cardiac surgery, as you mentioned too. So I think that's still an area of significant interest.
Interest and debate. And actually, for the PAH cohort, it is well known that it's recommended for only with the idiopathic PAH. So you would not do the challenge in somebody who has scleroderma or any other underlying comorbidities with PAH. For the heart failure, there are two groups of thought. One is if somebody has a elevated PA pressure and obviously volume overload, that the recommendation is not to perform the nitric oxide testing for the fear of inducing pulmonary edema and danger to the patient. Now, if you have somebody that you want to prognosticate from a surgical standpoint, whether it be valvular and so forth, and they're reasonably well compensated, there is a role for using nitric oxide, and we use it in not as high as we use for PAH, probably in the range of maybe no more than 20 parts per million, and maybe about 5 minutes or so, and then there's nothing really to indicate that using higher gives you any more valid data. But the question is, what numbers are you looking for to signify that the result you get will have a good reflection on your outcome? And depending on the group you read, and also with what kind of surgical modality they're undergoing, some group have suggested coming down to mean PA pressure of 30 or less. Some have suggested 40 or less. Some have also used that in conjunction with PVR of 3 or less, some 5. So there is different set of variables depending on who you speak to and which paper you read. But I think one, it does have a place, especially if you have somebody that has an obvious RV dysfunction, but they're not so end stage, and you know that there's some reversibility. And 2, that this will definitely give you a clue for prognostication. And the one that we have used, and talking to my cohort, that's sort of been agreed upon, is to go for mean PA pressure of less than 30 and PVR of less than 3. And that, you know, that group is definitely a very well-preserved group, no matter what number you start off with. If you end up in a PVR of 5 or less, and with mean PA pressure of 40 or less, that is a little bit higher risk, if you will. If you have a group that you cannot even achieve those kind of hemodynamic measures with NO testing, that's probably more of an irreversible RV dysfunction and more of a fixed type pulmonary hypertension.
I may have missed the thrust of this talk. I think the thrust is harking back to mitral stenosis and pulmonary vascular reactivity. The way I look at this is there's no way to get rid of the pulmonary hypertension unless you treat the mitral stenosis. There should be no way to get rid of all of this problem unless you treat the LV dysfunction. And I think that's where the primary cause is. And harking back to the people with mitral stenosis, you know, they live longer than 5 years. These people don't live that long, so you have to catch these people very early on in order to.
So going back to your thought, I remember in the days we saw mitral stenosis, there was a time that Dr. DeBakey had 100 patients in the hospital coming from all over the world, and we saw a lot of mitral stenosis. It was very interesting because sometimes some of these people, if you could nurse them through the post-operative period, their PA pressures would come down, but it would come down over a long time. It would not come down quickly, which goes back to some of what you're saying. if you relieve the left atrial pressure, even if there is pulmonary vascular reactivity, maybe time might make things better. And these patients are being made worse by the fact that they're getting a double whammy. We are not effectively lowering the left atrial pressure because we even have trouble with that. And then we have the pulmonary vascular component, both giving them a double slap. If we could have an effect, what you're saying is, if we could have an effective way of lowering the left atrial pressure, maybe over time, they would actually potentially come down. And I think that's a very valid point. Because mitral stenosis told us that that could happen. Yeah.
This question is kind of similar to that. In all of the heart failure with preserved EF trials, they didn't require a right heart cath.
No.
So they didn't require you to demonstrate that there was pulmonary artery reactivity.
No.
So do you think that that may have led, because diastolic heart failure with preserved EF is such a diverse population.
Yes, it is.
Do you think that that may be why all of the pulmonary hypertension drugs have failed in this population?
And I think that's been stated, and I think that is a valid point and argument. All the ones, especially the earlier ones with Bosentan, with the ERA, and then they studied over 3,000 patients. It was only echo guided. There was no PA pressure elevation requirement, and the ERAs were used not to target the pulmonary vasculature, but as another way of inhibiting one of the pathways for heart failure. And now we recognize that even though the receptors may be present in the myocardium, actually the where is more present is in the pulmonary endothelium, and that's where this drug works. So if you don't have pulmonary hypertension, actually you're going to get the negative effects of the drug, which is salt sensitivity and fluid overload, and not the beneficial effect of what you get from blocking the ETA. So you're absolutely right. And now we're learning from the mistake, and in the clinical trials that we're doing, we are requiring for them to go right heart cath, better phenotype the patient population so that we have a chance of targeting the group. However, we are still arguing over the fact that what is the meaningful definition for indication for entry criteria. We still don't know this, actually. I mean, do you use the DPG, TPG? That's why this argument, this discussion has been going on and on and on. And there's still debate, and I don't think there's any consensus as to how to really uniformly target these individuals.
All right, the hour is late. I want to really thank everybody for staying a few minutes later, and Dr. Park for great presentation.